Next up, ladies and gentlemen, we'll continue with the next segment. So please stay on the webinar with us. Now, as we get ready for the second session of the webinar, we will have more medical insights to be shared. So without further ado, let us move on. And our next medical session will have 3 more medical specialists joining us. And we do know that all of you do have some more questions during this session. So once again, let's take a look at how you can pen down your questions. There is a Q&A section where you can type your question in. So once your question is approved, it will appear under the live questions list. So without further ado, let's kickstart today's session. The second session today, we'd like to welcome Dr. Chee Keong, neurologist at Mount Elizabeth Hospital. His main clinical interest is in acute stroke treatment. His topic today is from insomnia and headaches to erectile dysfunction and memory fog, the long reach of COVID brain. Let us welcome Dr. Wee.
Good afternoon, friends and colleagues. Thank you for spending time with us this afternoon in Mount Elizabeth's annual medical seminar. My name is Chee Keong, and I hope to use this time to share with you what we have learned about the long-term consequences of COVID, specifically the neurological complications. So my talk today is entitled Insomnia and Headaches to Erectile Dysfunction and Memory Fog, the Long Reach of the COVID Brain. Now, how we study COVID, how we study any illness is typically in this sequence. We define the illness, we talk about the incidence, we try to talk about the pathology, and then we tell you how we treat the illness. But if you were to apply this to long-haul COVID, we will immediately run into problems, and this is how. Now, the problem is long-haul COVID wasn't a term coined by doctors. In fact, what we knew of COVID initially from reports from Wuhan was that this was a relatively short-lasting illness, lasting between 2 weeks in mild cases or 3 to 6 weeks in more severe ones. However, patients experiencing COVID or recovering from COVID experience a plethora of symptoms that were not previously described, and hence they form support groups on Facebook and Twitter to describe their problems and support each other. The news media picked up on this, particularly when a professor of tropical medicine also experienced COVID and discovered that he had a lot of symptoms, a lot of fatigue as he was trying to get over these COVID illnesses. Long-haul COVID was a term actually coined by Amy Webster as a name for the COVID support group on Facebook. Long COVID term itself probably came from a hashtag. Given the difficult definition, let us try to look at the incidence of long-haul COVID. Again, one of the first papers that came out was the result of a patient-led research group. An online survey of 3,000 participants with confirmed or suspected COVID-19 across 56 countries grouped together on an online web survey to describe their recovery symptoms. In all, a massive 203 symptoms across 10 organ systems were found. Now, if we were to look at the incidence of all these symptoms, we find that actually there is an increased frequency of neuropsychiatric or cognitive symptoms such as brain fog, memory issues, slurring of words, and speech and difficulty like me stumbling over some of these words. And so COVID seems to affect the brain in unusual frequency. Of course, online web-based studies have their limitations, and a better paper would perhaps be one based on cohort studies. So over here, we have a paper by Maxime Tauquet et al., which used linked electronic records of about 59 healthcare organizations, mainly based in the US. And in this cohort, they had about 273,000 COVID survivors. Using the more frequently described symptoms of COVID, they tried to hunt the EMR, they searched the EMR for symptoms suggestive of this that would correspond to the symptoms described in the earlier studies. And this included chest pain, abnormal breathing, abdominal symptoms, fatigue, malaise, anxiety, and so on. What they found was that about 57% of patients had either one or more long COVID features during the whole 6-month follow-up period. Interestingly, another 37% or so only got the symptoms between the 3rd and the 6th months of the study period. And when they compared this to patients recovering from influenza, COVID seems to give more post-stromal or recovery symptoms than other viral illnesses. To study the incidence of long COVID further, we have a paper from Jennifer Loke published in JAMA Open in February this year. And this was a single center study with 234 participants who contracted COVID between August and November 2020. And they were given a single follow-up questionnaire to fill up between the 3rd and 6th months after disease onset. Because it was patients were accrued over a range of a period of time, the median follow-up was about 169 days. And overall, about 37% of the adult patients who had COVID experienced long COVID symptoms. And about 31% of those who had more severe illness and were hospitalized also complained of long COVID symptoms. Predominant among them were fatigue and loss of sense of smell. And from the chart below, it seems as if that those with more severe illnesses had more frequent long COVID symptoms. So here we describe that patients have memory fog, insomnia, and headaches. But how does that happen? Well, we're not entirely certain, but to give us a clue, we can look into acute pathology of the CNS in patients with COVID infections. Now, McAlpine et al. From the Yale University found that patients with COVID were more likely to have ischemic strokes. And this was linked, they found in their study, published in Stroke June 2021 this year, to be linked to various markers of endothelial dysfunction. Specifically, patients who had stroke when they had acute COVID seem to have higher levels of von Willebrand antigen, higher levels of factor 8 activity, and von Willebrand factor activity, suggesting endothelial dysfunction occurs in COVID stroke patients and led to them having a stroke. What about those patients who did not get a clinical stroke? Well, Lee et al. In a post-mortem study of about 9 patients performed high-resolution MRI studies of post-mortem brains in such people. And what he found was that there were punctate hyperintensities representing areas of microvascular injury and fibrinogen leakage in these patients. And when they performed a corresponding histological study in these patients, they found in the slide over there, you can see, there was evidence of fibrinogen leakage in the aphthous context of these patients. But there was minimal perivascular inflammation and there was no vascular occlusion. Slides B1 shows you the intact vascular structures as well as the basal lamina of these patients, and B2 shows you areas of fibrinogen leakage. Importantly, PCR for SARS-CoV-2 virus was negative. So COVID seems to cause immune-mediated endothelial dysfunction acutely in patients who suffer from the COVID infection. What else does it do? Well, Song et al. Studied the CSF of patients who had acute confusion or CNS features when they had acute COVID infection, and they found interestingly that CSF patterns of immune response differed from those in the serum. More importantly, there seem to be autoreactive antibodies produced within the CSF itself. What about post-COVID patients? Well, Mrna et al. In their single-center prospective cohort study of about 230 patients, studied psychopathological symptoms in patients about 3 months after hospital discharge. What they used was self-rated rating scales such as a Beck Depression Index, as well as the Zerk self-rated depression scale. They corresponded this to inflammatory markers during the acute infection and at 3 months of follow-up. Very interestingly, patients who had higher levels of systemic inflammation seem to have more depressive symptoms, and the rate of change or the rate of decrease of these inflammatory markers corresponded with improvement in their depressive symptoms at 3 months. So although we do not have a specific cause, it all seems to point towards an immune or inflammatory related pathology. What else have we got? Well, are all the symptoms real? Well, Zhao et al. In the European Journal of Nuclear Medicine in January 2021 researched patients with long COVID symptoms using FDG PET. What they found was a specific pattern of glucose hypometabolism in the bilateral rectal orbital gyrus, the olfactory gyrus, and right temporal lobe, and this could very well account for the symptoms of memory fog and insomnia. And very interestingly, in the charts below, they found that the degree of hypometabolism corresponded with the degree of symptoms. The lower the metabolism, the more the symptoms. What sort of cognitive problems do patients have? Well, we can look at Becker's paper, which was published recently in October 2021. This is a cross-sectional study of 700 papers. I shall speed through this a little bit, given that we are running a bit out of time. But most prominently, well, patients were found to have reduced processing speed, impaired executive functioning, and as well, problems with memory occurring about 20 to 25% of these patients. So this is memory fog characterized. And if you look into the details of the chart, it seems as if patients who had more severe COVID illness, who were hospitalized, had significantly more symptoms than those who were managed as an outpatient. Now, we have talked about memory fog, we have talked about insomnia. There's just one more thing about the nervous system, the part that we need to get us up and running. That's right, we're talking about the autonomic nervous system. Now, COVID dysautonomia was found, dysautonomia was found in about 50% of post-SARS patients in 2002. So we expect to have dysautonomia similarly described in COVID patients. The figure seems to be much less. Based on the initial study of 214 patients in Wuhan, we only had about 16% of patients reporting the symptoms. A retrospective cohort of about 800 patients in Spain only found this in about 2.5%. So what is the cause of the difference? Or is it because we're not looking out for it? Or does COVID just cause less dysautonomia? We are not certain. But to characterize this further, the authors from Mayo published their autonomic studies on a cohort of 6 patients with symptoms of autonomic dysfunction. And I'd just like to share them with you. The 6 patients, both male and female, most predominantly reported autonomic symptoms of postural lightheadedness. They have syncope and near syncope. And formal autonomic tests were done. Some of them were found to have orthostatic hypotension, the rest postural tachycardia, which is consistent with POTS. And of course, autonomic system is responsible for other things like erectile dysfunction, which we have mentioned in the subject title. Having discussed the span of neurological symptoms in COVID, let us now talk about treatment. And there's nothing. Nothing has really been proven to work for long-haul COVID symptoms, but again, we derive some hope from preliminary studies, again based on patient cohorts. Now, this is a preprint paper in Lancet, prepared by Staines Group, okay, from the University of Exeter. So this is what I've done. I've gotten, again, a web survey ready for participants, 800 of whom joined in this study, who had long-term COVID symptoms. And these participants all received post-infective vaccinations, COVID vaccinations, either with the AstraZeneca or similar virus-derived vaccines, or the mRNA vaccines. In total, about 58% of them reported improvements in their symptoms, but about 18% of them reported deterioration, and the rest of them reported no change. Larger improvements in symptom severity score seems to be associated with the use of mRNA vaccines and less in those receiving adenoviral vector vaccines. But obviously, this is an interesting observation, a suggestion that there is an immunological basis to this long COVID symptoms, but not something that we can still use for patient care until we have a proper study. With that, I'd like to thank you for your time this afternoon. Thank you for spending time with us, and I hope you have an enjoyable day.
Thank you, Dr. Wee. Coming up next in our presentation, we have Dr. Cindy Hia, Paediatrician and Paediatric Cardiologist, practicing at Mount Elizabeth Novena Hospital. Dr. Hia's topic today is on keeping your child safe, prevention, vaccines, myocarditis, and mental well-being. Let us welcome Dr. Hia.
Hello, good afternoon one and all. I'm Dr. Cindy Hia, and my topic today is keeping your child safe, using vaccines, myocarditis, prevention, and mental well-being. Okay. So, keeping your child safe begins with keeping your child healthy. In 1948, WHO made a statement to say that the state of complete physical, mental, and social well-being is a state of health and not just merely the absence of disease or infirmity. Well, a healthy child actually has infections, quite a few infections every year. In the first 1 to 2 years of starting school, the child will have 8 to 10 infections per year. And in the subsequent 1 to 2 years, another 6 to 8 infections. And then in the last 2 years, they would have about 4 to 6 infections per year, and then that roughly that throughout their whole life. The common infections include the common cold, bronchitis or bronchiolitis, gastroenteritis, which is mainly viral, childhood exanthems such as hand-foot-mouth disease and exanthum subitum, and also some bacterial infections, commonly bacterial pharyngitis and acute otitis media. Now, there are 3 definitions of health we can think about of today. One of them is the absence of disease. The second one allows the individual to cope with all the demands of daily life, also implying the absence of disease or impairment. And lastly is to maintain a state of equilibrium that an individual has established within himself, his social and physical environment. And so when we try to promote health, we can look at this in terms of the different definitions. So if we are looking at the absence of disease, for instance, at the start of the COVID-19 pandemic, we tried to eliminate the virus. Now, and then we found that it was a little bit difficult to cope. So the government actually had started to roll out financial aid to the population, and that actually enhances the person's ability to cope with his environment and also to lead a healthy life. And lastly, now that we are entering the endemic state, we are now trying to maintain a state of equilibrium. So we want to actually take preventative actions such as giving vaccines, seeking early treatments such as antiviral treatments, and that would be in harmony with the individual and his or her community's values. And do remember that the values of each individual is actually shaped through life under the influence of the parents, the friends, schools, media, law, and one's own life experience and cause. Now, vaccination is no stranger to the child, as the child has to undergo many immunizations during their early childhood. And we have successfully been able to contain quite a few of these childhood infections. But the common cold is the one that has been quite elusive. And so the rhinovirus actually consists of 30 to 50% of the common cold infections, and there are 100 different serotypes of rhinoviruses. The coronavirus actually makes up about 10 to 15% of the common cold, and up to today, there's no vaccine available for both the rhinovirus as well as the coronavirus. The coronavirus is a little bit tricky because it hops from humans to animals and vice versa. But when this global pandemic was declared by WHO on the 11th of March, the vaccines were then developed to combat this pandemic. And to expedite the process, there were many combined phase 2 and 3 trials. Finally, on the 2nd of December 2020, UK was the first country to roll out the vaccines under the emergency use authorization. This was followed quite quickly by Canada and US. But what happens is that we do have to remember that at that point in time, the vaccines were not approved, but they were granted EUA because of a public health emergency declaration to support its use during the pandemic. And as October 29th, US FDA had granted EUA for children 5 to 11 years of age. Vaccines, we have to remember that vaccines must be given with informed consent. And in June 2021, one of the articles published actually advised healthcare professionals providing vaccinations throughout to thoroughly communicate and educate vaccination recipients on the information present on the fact sheet provided by the CDC. Recipients should also be informed on the VSafe information sheet so that they can actually inform about their adverse events through these portals. Now, the providers should also register any unusual or severe adverse effects to the Vaccine Adverse Event Reporting System. And the vaccine provider at that point in time in June 2021 were advised to inform pregnant women of the lack of sufficient data on the use during pregnancy. Now, this is of importance to us in terms of the informed consent because the government, MOH, is going to roll out vaccination for ages 5 to 11 as we speak. So I just received an SMS to say that we have to look out in our emails and there's a circular going to be sent to us regarding this vaccination. Now, the 12 to 18-year-olds have already been vaccinated with the adult formulation. The dose would be a 0.3 ml equivalent to 30 micrograms of the mRNA, and that is equivalent to the adult dose. Now, in patients 5 to 11 years of age, this dose has been modified and there's a new formulation being used. And this comes in an orange vial, 0.2 ml, but this contains 10 micrograms of the mRNA vaccine. So looking at the fact sheet that the Pfizer vaccine has rolled out, it says that the vaccine is indicated for active immunization to prevent coronavirus disease in individuals aged 5 years and older. And for the indications in pediatrics, the monograph has stated that the safety and efficacy of this vaccine under 5 years of age has not yet been established. Also, there is a serious warning and precaution statement which says that at the time of this authorization, which was published on the 19th of November 2021, there are no known serious warnings or precautions associated with this product. Now, this product is relatively new, the mRNA vaccine, and these are the constituents of the vaccine. Now, the first 4 products actually form a lipid nanoparticle which envelopes the mRNA vaccine, and the rest of them are actually stabilizers for the vaccine, solution in the vaccine for administration. Now, the adverse events that have been reported in the monograph states that in ages 12 years and above, especially in 12 to 15-year-olds, 226 adolescents were included in this analysis, and they found that 90.5% had injection site pain, 77.5% experienced fatigue, headaches in 75.5%, and chills in 49%. And the other two commonly experienced adverse effects were muscle pain and also joint pain. In the 5 to 11-year-olds, the data cutoff date was on the 8th of October, and there was a follow-up period of at least 3 months. 1,456 children received this vaccine, and there was injection site pain in 84.3%, and fatigue in close to 52%, headache in 38%, and joint pain in 7.6%. In the post-market analysis, they found that there were other adverse reactions that they were not expecting, and one of them was myocarditis. And it is reported that because these above reactions were reported voluntarily from a population of uncertain size, it is not always possible to reliably estimate their frequency or establish a causal relationship to product exposure. They were included in the monograph because they represent reactions that are known to occur following immunizations generally, or are potentially serious, or on the basis of their frequency of reporting. The long-term effects of this vaccine are not known, and currently the vaccines are deemed to be safe, but we have to understand that safety means no obvious clinical manifestation that causes harm in the short term. By definition, no long-term data is available. In looking at children, we have to think ahead, because if we give a child a vaccination at the age of 5 to 10 years old and their life expectancy is about 75 to 85 years of age, they would live for another 50 to 60 years not knowing what adverse events may occur. And given that the lipid nanoparticle technology and the mRNA technology are both relatively new, when analyzing data, one also needs to be very careful to understand that when a product has not been shown to cause a certain adverse effect, it is not equivalent to saying that the product has been shown not to cause a certain adverse event. So these two have to be taken into consideration. Now, we have to review mRNA COVID vaccine and myocarditis because this tends to happen in the young. For males aged 12 to 29 years old, this occurs in about 40.6 cases per million second dose, and males 12 to 17 years of age, 62.8 per million dose, and in males 18 to 24, 50.5 per million dose, in contrast to males who are more than 30 years of age with a incidence of 2.4 per million second dose. Now, I'm just going to skip through this few of these slides to just show you the, in the interest of time. Okay, so if you give the vaccine to the 12 to 29-year-olds, and per million doses, you would expect to prevent 11,000 cases, 560 hospitalizations, 138 ICU admissions, 6 deaths. But you expect an incidence of myocarditis from this vaccine of 39 to 47 cases. And if you look at this data, if you look at the second and the third columns, you would actually be preventing 2 deaths, but you would expect 56 to 69 myocarditis cases in patients aged 12 to 17 years of age. And that is actually quite a big number. And so what about myocarditis in COVID-19? Adult patients, as Edgar has alluded to, usually have some severe disease with a certain degree of cardiovascular involvement, including myocarditis. But in children, this disease tends to be pretty mild. And the one that is more associated with cardiac manifestations is multisystemic inflammatory syndrome in children. But this tends to occur in the school-going age. Please take note that this is of great concern because 90% of these cases require ICU admission, 80% require inotropic support, and 28% require ECMO support. And it is important to recognize them because all cases should be hospitalized for further management. And this manifestation is very similar to Kawasaki disease, but with the difference that these tend to occur in older children, and there are also gastrointestinal symptoms rather than just mucositis. If you're brave enough to keep the patient for a while longer, you may proceed with some basic tests like cardiac enzymes, blood tests, and ECG and echocardiogram. My personal take on this is if you see a case like this, just refer. All right, so to prevent infections in general, we have to keep our child healthy with good hygiene. Do not forget good nutrition, adequate hydration, adequate exercise and physical activity, and adequate sleep. Now, what happens is that we have to remember also that when we introduce vaccines, we are targeting mainly the adaptive immunity. The innate immunity is less differentiated, and we can actually work on it. And there are some of the normal traditional methods that may help with the innate immunity. Authors, as early as 2017, have published that because vaccines are difficult to develop for the common cold, consideration should be given to complementary alternative medicine and dietary supplements. Now, dietary supplements are not all hocus pocus, and they actually have done extensive research on dietary supplements. So just to show you, for vitamin C, okay, they have actually done research to show that it's beneficial to cellular function. It helps neutrophil chemotaxis, phagocytosis, and lymphocyte function. It's also a potent antioxidant, and then it's also a free radical scavenger that helps to reduce oxidative stress in the lungs. And also, it actually helps to protect the host tissue from excessive damage, and this is rolled out in studies which show that the recovery from pneumonia in the elderly actually is improved with vitamin C supplementation, whether it be a low dose or a higher dose at 500 to 1,600 milligrams per day. Vitamin D also has multiple studies done, and also do take note that a lot of these popular extracts that a lot of parents give their children, such as elderberry extract, they do actually have some properties. And honey also has got antioxidant properties, and it also stimulates phagocytosis and improves T and B cell function. Now, the mental well-being of infants and toddlers and children are also affected in different ways. To just say the least, infants actually start to have a new normal where they stay indoors, they have fewer social interactions, and toddlers also then sometimes develop speech delay. And in children and adolescents, the parents and the teachers do need to learn how to pick up some changes that the kids may undergo and to seek help early. So with this, I thank you.
Thank you, Dr. Hia. Next up, we have Dr. Elaine Chua, a family physician, and she'll be sharing on from acute to long haul an overview of the generalist physician's role in managing COVID-19. So let us welcome Dr. Chua, please.
Good afternoon, fellow colleagues. I'm Elaine, and I'm a GP practicing in a small town, Bedok, with 4 other doctors. Thank you, Parkway, for inviting me to share my thoughts on endemic or long-haul COVID. I'm the last presenter, and I requested to change the title of my slide to include the word overview, because long-haul COVID is really a very complex condition to talk about. Some of the slides are busy, and I won't be able to talk about everything. I'm told this seminar will remain available on YouTube in the coming months, so do feel free to refer to them at your convenience. The definition of long COVID is not specific to any symptoms. Any kind of symptoms that start from their acute COVID and last beyond 4 weeks, typically up to 3 to 6 months, can happen to anyone who has had COVID. So in the past, similar post-viral syndromes had been observed in the survivors of SARS and MERS. They report residual fatigue, dyspnea, chest pain, cognitive disturbances, arthralgia, general decline in their quality of life. This in 2015 had been coined myalgic encephalomyelitis, or chronic fatigue syndrome. There is not much awareness about this post-viral fatigue syndrome, and I think it's important to talk about it a little bit because it does impact the patient's ability to function or cope with their daily living post-illness. And because so many people are expected to contract COVID, this can become a significant burden on the community. This slide, I've included 2 news articles from the Straits Times that were published July 2021 on the left, and the other one October 2021. The initial news article was based on the NCID study that stated 1 in 10 recovered patients potentially still have symptoms 6 months after the initial COVID infection. And the second one published the symptoms of long COVID, so that this is public knowledge. So as everyone knows, ACE2 receptors are expressed in many organ tissues. So it's really a very complex multisystemic effect of COVID-19. With the majority of COVID patients now on home recovery program, these patients will not be captured by tertiary centers. They will come to the GP or their usual regular family physician. So it's important for us to recognize if it's related to their initial infection. I want to quickly go through some of the presentations that may turn up in a GP office after their isolation of only 10 days. Rashes are common in acute COVID. Luckily, they tend to resolve spontaneously. Majority, 50%, are maculopapular rash, and there are some with urticaria. We treat them symptomatically, and the rest can be observed and expecting to resolve. The main presentation at 6 months is hair loss, mainly due to stress, telogen effluvium, which is a pleasure to treat because you know it goes away. Renal deserves a mention. The original Chinese study from Wuhan stated that up to 13% had reduced GFR at 6 months, even though they had no recorded kidney injury during the acute phase. The study did not quantify the drop in GFR, but it's important because it will affect our prescription practice. Hematologic, we know that thrombotic events can occur in higher frequencies in the post-COVID patients. In a study from USA, 2.5% cumulative incidence of big thrombotic events like heart attack, strokes occurred with a median presentation at 3 weeks. Locally, there was a study from NCID that even the asymptomatic migrant workers with initial COVID infection without symptoms, they had low cardiovascular risk. They had 4 cases whereby some had acute stroke, heart attack, and one guy had ischemic limbs. This endocrinology box is frequently missed because they can present very non-specifically, maybe just with fatigue. There have been some correlation with diabetes mellitus occurring in the post-COVID patients because ACE2 receptors are expressed in the pancreas, but we're not sure of direct causal relationship or just unmasking of underlying tendencies. Just important to screen them for it. They present with the common post-COVID syndrome of fatigue. And important to note in our at-risk patients, whether they've had some deconditioning because they have been isolated at home. I've had an 80-year-old who normally attends daycare, now forced to stay home for the past 10 days without her usual activity. So this is a busy slide. I was expecting some of my previous speakers to elucidate more about the cardiorespiratory symptoms, which account for about a third of long COVID. And then there are also another third of the patients with neuropsychiatric symptoms, from sleep disturbances all the way to PTSD and anxiety and depression. There was already mentioned previously a long COVID study in an international cohort, 3,000 patients, self-reported symptoms at 7 months, up to 96% of them still have symptoms. But I think we need to beware of recruitment bias, where maybe some of them still having symptoms because they had more severe COVID in the beginning. So I just want to briefly touch on this syndrome, chronic fatigue syndrome, because like other chronic fatigue syndrome patients, those with post-COVID have mentioned being dismissed by healthcare professionals because of reduced awareness. This syndrome can occur from patients as young as 2 years old and up to as old as 77 years old. A German study of patients ill 6 months after mild or moderate, even mild COVID, found that actually half of them met the criteria for chronic fatigue syndrome. However, to note that the study only had 42 patients and it's a preprint. So there's some unique symptomology that I think we should take note of. Typically, patients report post-exertional malaise. We tend to feel endorphin release and feel good after exercise, but I think prescribing exercise to this group of patients may actually make them feel worse. And on questioning their sleep, they may report having sufficient hours of sleep and not having frequent awakening or shortened sleep, but they still wake up unrefreshed. And in order to satisfy the criteria of chronic fatigue, they actually have had to have symptoms for the past 6 months, resulting in substantial reduction or impairment in their ability to engage in pre-illness activities. Okay, and some of these symptoms may have to include cognitive impairment or orthostatic intolerance. I think it becomes important in society because they impact the person's ability to function, and with the large amount of patients expected to contract COVID, we're looking at substantial numbers. The evaluation of fatigue, as you can see, is complex. There is a long list of differentials, and it's important to bring up because we don't want to miss any treatable organic cause of their chronic fatigue. So we go back to asking the patient. We have Chinese patients who just report that they are chuan or bolan, and then we have Malay patients who just typically penat or basically fatigue, right? But actually they mean they have cardiac symptoms. And also hematological, whether there's any pre-existing risk for anemia, whether they have any higher risk than usual of blood clots, whether they have any symptoms suggestive of chronic inflammation, like morning joint stiffness, which may not be present while they are in our clinic. Endocrine is an important segment to screen for because they can present very non-specifically as well. Diabetes can present with just fatigue, tired all the time. Thyroid family history, risk for HPA suppression because some of our patients, somebody mentioned TCM just now, and it's true in our local context, a lot of our patients are on TCM and they may have stopped their TCM because they were ill. Or they've taken something that they're not sure what is the component of, and they present to you many months later with just fatigue. Neuropsychiatric symptoms are always screened for sense of wellness in my patients with a basic PHQ-2, ask about their sleep, and the most important part to screen is how has it been affecting their day-to-day function? And of course, in our at-risk patients, general deconditioning, keep in mind sarcopenia and whether they have been screened for osteoporosis, because now they're at increased risk of falls. So the investigations will be driven by what you find in the history, whether you want to send them for at least do a basic ECG in our office, whether you want to send them for a spirometry, consider D-dimer screen, and further investigations. A basic hematological as well as metabolic screen is called for. Neuropsychiatric evaluation, especially the social evaluation, which becomes important in our management prescription. As I mentioned, general deconditioning, whether we want to send them for a BMD test, office timed up and go test to assess for fall risk. So this is from BMJ review article, and that is a long list of tasks for the physicians to follow up with. I just want to emphasize that we have to contextualize the prescription of treatment for the patient with regards to their function at home, function at work, function in the community, because we don't want to worsen their symptoms by giving them a task that they cannot fulfill. Yeah. So with appropriate referral for, if we find some organic problem, drug therapies, rehabilitation for those who need, who have undergone deconditioning, counseling and social support. I want to pause a little bit and talk here about something that we may not always remember, but our interaction with the patient, even a short consultation can actually be considered a therapeutic relationship or therapeutic encounter if we don't forget that, in the Chinese context, we understand that people who have just combated a severe illness, they have low Qi or low energy, right? So, and then we give them time to pace themselves and get back to usual. We talk about dietary, nutritional support to help them regain their energy levels. Yeah, and so not to forget that our interaction with the patient can include this brief therapeutic counseling, remind them of their existing social support system so that they can get back up on their feet. And then in primary care, we allow for easy access, follow-up, re-evaluation of new or developing symptoms. We know our patients well. For many years, we look at them. Sometimes the symptoms don't present all at one go. We don't have to do all the evaluation at one sitting. So that is important for them to remember. They can always come look for us to reassess. I think Miss C is important not to miss. This is from the MOH circular. Some of the kids we see, we do not send them for PCR or swab testing. So I think it's important that anyone who presents even with the first day of fever, we need to follow them up a little bit more closely, maybe even daily follow-up. And if they happen to continue having fever or have developed more than one system involvement, to refer them on early, because it's important that we hospitalize them and treat them early. And thank you very much. That is the end of my talk. I can be reached at the following email address. Thank you.
Thank you, Dr. Chua, for your talk. And as our speakers get ready for the last panel discussion, I hope that all of you watching us live right now can also get ready your questions for the Q&A. And this is how you can do so. Now, for the Q&A, do remember to continue to put in your questions via the Q&A function that is located at the bottom of the webinar screen. Now, for those of you having the referrals for your patients to see Mount Elizabeth Hospital's specialists within one day, do use this hotline or WhatsApp. Again, this event would not be possible without the support of our gold sponsor, Sandoz. So thank you very much. And now we've come to the last session of the Q&A for today. On site with us right now, we'd like to invite back Dr. Leong Ho Nam, the infectious disease specialist, to moderate our Q&A session with our three speakers. So once again, let's welcome Dr. Wee, Dr. Hia, as well as Dr. Chua.
Thank you. I thought we had another great session earlier on. And we touched on quite a few things, from neurology to kids and vaccinations to even supplements, and finally about long COVID. Okay, we do have questions coming in, and you see this, which I'm holding it. the questions which you post in comes into me and you get voted in terms of popularity. And I'm going to let Dr. Elaine have a rest first. I'm going to jump straight, okay, to our neurologist, improving memory fog. Okay, I mean, as you all know, I had SARS before. I was trying to use your slide and say, my wife, I forgot this and that, it's because of SARS. But she's going to tell me, is there anything I can take to help me improve my memory fog?
Now, Dr. Leong, you don't have memory fog. If you forget your wife's anniversary, it's not because of SARS. Anyway, memory fog is an interesting thing. Now, scientifically, we don't really know what causes memory fog at the moment. It's still a topic of intense research. Although there is some suggestions that this is all immunologically related, and I showed you guys a preprint article that suggests that post-vaccination after a COVID infection, some patients do improve. There is still no proven therapy. Now, so I will hesitate to say that there is treatment, but perhaps symptomatically there are things that we can do for a patient who has memory fog. There are multiple devices now we can use in lieu of the memory these days. For example, 8 memoirs, notepads, or these days handphones that we use regularly to remind ourselves of tasks that we have to fulfill, including our wife's anniversary and birthday, and many other modern tools we have to help us with all those things. But other cognitive impairments with long-term COVID, for example, executive planning, these are a lot more difficult to treat. But I think there is hope on the horizon, namely in a few ways. Firstly, there's a lot of research going on. Secondly, if you were to follow the blogs of those who have long-term COVID symptoms, many of them do report as time goes by that there is significant improvement in their symptoms. And so while we await the discovery of new treatments, there is hope in the air. Hang tight. And if you do need further help to see a neurologist, we will try to see if there are other supportive therapies we can do to help you. So back to you, Dr. Leong.
Okay, just a quick, do you think a 1 minute answer, slight dementia after COVID, is there anything you can do for that?
Well, so dementia is not actually an illness. Dementia is a syndrome that is usually caused by various underlying conditions. For example, Alzheimer's disease or vascular dementia being the most common. Now, if you have dementia after COVID, then I wonder, are you truly demented, or is this just a post-COVID cognitive sequelae? And I would definitely hesitate to label a person as having dementia right after they have a COVID infection. So I think this is something that my colleagues in neurology are well aware of, and we'll be taking suitable cautions before we give a patient such a label or diagnosis.
Okay, I'm going to ask Dr. Chua here. The one of the questions was, what about long COVID in children? Do you think you can give us a short summary on it?
I think I will have to defer to my paediatrician colleagues.
Okay, yeah. So what happens is that in long COVID in children, the symptoms are a little bit different from adults. So what happens is that they do have the fatigue, they do have a little bit of myalgia, tiredness, but they also have some of them report persistent runny nose. So these symptoms tend to go away on their own after about 12 weeks, and most children fully recover. And for those children who have developed multisystemic inflammatory syndrome in children, they found that actually post-COVID, when they've done the MRI for the children, their hearts are actually quite pristine. So again, I think children are relatively spared even if they've developed COVID-19.
Okay. I have the permission of the 2 chairs of CME committees to not deal with just the safe questions. And so one of the questions I'm going to follow up with Dr. Cindy here is this. The 5 to 11 years old, they have actually very mild illnesses. Then should we actually encourage vaccination? And the caveat is this. At this point in time, children vaccination less than 12 years old have not been approved. Not approved. I'm talking about a non-approved situation. but we expect it to be approved shortly, just like the States. What's your take on it, given that 5 to 11 is actually quite mild?
Okay, so a few things we have to consider. One of them is that we have to look at it from two different points of view. One is that if we look at it as a physician or whether we look at it as an epidemiologist. If you're an epidemiologist and your primary concern is to look at the population and the health of the population, your deductions after all the data has been presented may be quite different from a physician. As a physician, I'm sitting in front of the patient, and the patient's mother is asking me, should I take the vaccine or not? My answer may be very different compared to the Minister of Health, right? So I think we have to also strike a balance. The thing is that in children 5 to 11, the disease is very rare. 50% have no symptoms, 50% have mild symptoms. Only 1% require hospitalization. And the hospitalization for this 1% is actually due to sometimes bronchitis, pneumonia, gastroenteritis, and dehydration, and very rarely a handful of cases from multisystemic inflammatory syndrome in children. So I think we have to take that into balance. Now, the 5 to 11-year-olds are receiving a different vaccine, and so they are receiving 10 micrograms of the mRNA vaccine with a different buffer. It remains to be seen what is the effect downstream, so I really am not able to give you a direct answer. But we have to weigh the pros and cons at that point in time. And also we have to take into consideration what is happening in the environment at that point in time. Is it a variant that is deadly, or is it a variant that is mild? If it's a variant that is deadly, then I suppose it makes sense to vaccinate. But if it's a variant that is very mild and the children are overcoming this disease, then we have to think twice about it. So there's no straight answer to this, but I'm just giving you some thoughts that may help parents make their decision or physicians make their decision for the patients.
May I
Yes,
have this
please.
moment, Dr. Leong, with your permission?
Yes, please.
Sorry, Dr. Leong and I have been friends for many years, so we are a bit less formal. But Dr. so now I'm a parent now, I'm not a doctor, and I'd just like to cop a free consult from you. Sorry, so I was wondering, because before this thing came out, I was very worried that one of my sons, I've got 3 kids, might catch COVID because he has got status aspergicus. And he was admitted to the ICU once before and very nearly required intubation. So I was thinking, if the vaccine ever was approved and was proven to be safe, then my son with a pre-existing respiratory condition might be a person I might take special care for to consider for this sort of vaccination.
Yes.
Would there be other children with a similar risk factor that you would
So
think?
in NHS in the UK, the guidelines are quite balanced. So before they actually rolled up fully vaccination for 12 years and above, the guideline was actually children who with significant comorbidity, children who are in homes and who are at risk of developing severe COVID infection should actually take the vaccination. Whereas those who are relatively well and would come out relatively unscathed from COVID, then maybe we should think about whether or not to vaccinate. So I think this is a very balanced view.
I agree. Okay, I'm going to jump in here and say a few things. And one of the reasons why I asked Cindy about what is long COVID in children is that there are studies to say that long COVID exists in children. We're talking about risk of between 10 to 40%. So do you then go for mild illness, or do you end up with long COVID, or do you end up with a potential complication of the COVID vaccine? And so far, the COVID vaccine risk for the children is actually extremely low. And yesterday, my heart sank. My heart sank for one reason, because an infant died of COVID-19. This is a disease which is supposed to be mild for children. But when it happens to your own child, the statistics don't count anymore. The statistics don't count because it hits right at home. So coming back then, who will die? Who will benefit from a COVID infection? Who will benefit from the COVID vaccine? At the end of the day, it's a little bit of a roll of the dice because we don't know and there are no predictors. Now, the good thing for Singapore, and this is what I always say, is number one, we are not the first few countries to do vaccinations for children. The US are ahead of us. They've at least, at the last count, there were 3 to 4 million children who had gone through it. And in time, we're going to see data coming out to see the safety and efficacy of the 5 to 11. Number two, with that, we can then compare against the risk benefits of the vaccines versus risk benefit of the illness. And indeed, I think Cindy's really hit the nail on the spot by saying, what about Omicron? If Omicron comes out to be really harmless for children, and we don't see the neurological complications or the cardiovascular complications, and we hardly see any MISC, and we have no data on MISC in children for Omicron, then do we need a vaccination? So it is a big unknown. Okay, so for the listeners, for the viewers now, my suggestion is this. Number one, you don't need to make a decision now, especially in Singapore, there's no approval for it. But watch this space, watch the data. As the data comes in, you get to see clarity, granularity on how good the vaccine is, what are the problems, and in fact, things change. You get Omicron. Will there be another Optimus Prime that will destroy Omicron? There may be. And when that comes along, there may not be an issue anymore. And so that comes much later. I'm not going to let go of Cindy yet, okay? I'm going to ask her one question. Okay, I'm going to push her back 2 years later. 2 years later, let's say the vaccine is approved, it's found to be safe for 5 to 11, in fact, 6 months and above. Do you see this vaccine coming into play as part of the childhood vaccination prevention program? Okay, this is 2 years later when we have good safety data. Do you see that happening?
So I'm going to throw the net a bit wider in the sense that this may not be the only vaccine that is approved 2 years down the road, because we have other types of vaccine, whole cell vaccines, subunit vaccines, or other things that come into play. So I think we have to look at the data accordingly then. But at that point in time also, as I come back to my point again, what is the disease severity in the community? And then apart from the disease severity, what is the burden on the community? How many days off work the mother is going to have, or how many days off school the child is going to have? This needs to be taken into consideration as well. And then lastly, is this virus still going to keep mutating? If this virus is still going to keep mutating, are we going to keep up with it? Do we need booster after booster after booster? So I think these tend to be sort of must be taken into consideration. Now, childhood immunizations, we are talking about things like measles, very stable, rubella, very stable. Yeah, so diphtheria, tetanus, pertussis, bacteria, very stable. We're not having these crazy mutating viruses, and I think that actually makes me think about whether or not it should be part of the childhood immunization. Maybe there is a vaccine that can actually give some partial protection against this cold, and then maybe reduce the severity, something like a rotavirus vaccine, where you have many strains and you may not stop every strain from occurring in the child, but the disease severity is reduced such that mortality, morbidity is all down. So I think if that is the situation at that point in time, I think yes, we should consider that as part of the childhood immunization program. I hope it's a fair answer.
I think it's a very fair answer. In fact, I'm very sure HSA as well as the Ethics Committee on Vaccination will go through the same questions, and I agree with her. My take is that eventually I don't think it will happen. Why? You see, there are 4 other coronaviruses that were there, there are actually 5 or more. 5 or more coronaviruses that are there even before the occurrence of SARS 2003. So what it means is we actually have been living with coronaviruses all this time. So for all you know, it becomes a common cold, you get a runny nose, and that's the end of it. Okay, again, I'm not going to make this a safe pedal discussion. I'm going to jump to the neurologist, the one who's really smart. If I was smart, I'd become a neurologist. And what the question is this: we have people who had reports of strokes after vaccination. Can you share with us what's your take on it?
Well, firstly, the smart one here is Dr. Leong. Now, how do we put it? Now, strokes after vaccination. Yes, I've heard of stories of people having strokes after vaccination. Now, whether vaccines are a risk factor for people developing strokes remains to be known. We await data from countries around the world and our own epidemiological data. One of the problems we have about knowing whether agent or intervention is a causative factor in the disease occurrence is this, that how much above the baseline rate does that intervention raise the frequency of the disease. Now, stroke occurs in about 8,000 patients a year in Singapore, and about 1 in 5 people are expected to have a stroke in their lifetime. So that's a pretty high frequency event, and it's very hard for us to detect increased signal so quickly. But be that as may be, even if the vaccine does, and that's just me conjecturing, even if the vaccine does increase the risk of stroke, the fact that we haven't heard much about it, the data doesn't prove it, means that even if it does increase the risk of a person getting a stroke, it must be really very small. Now, to that end, I think we should look to our National Registry of Diseases, of which I know Dr. Ramani, who's in the audience right now, is helped to organize, and he's still helping to look at the data from. We await the NDRO to tell us the latest data to see whether we have a signal for increased incidence of stroke in these few years that we are rolling out the vaccine. Now, we discussed the theoretical basis just now, Dr. Leong and I, about on why a vaccine could potentially lead to a person having a stroke. Now the coagulation pathway in the body is always balanced between thrombosis and anticoagulation. Now we know that the reason why, or rather the theoretical reason why a person might have increased risk of stroke in the peri-operative period is because there's a relative pro-inflammatory state, which is pro-thrombotic. So if I were to conjecture, if it's really true that the vaccine does cause increased risk of stroke, that it might be because it provokes a relative pro-inflammatory state in the body right after administration, and that might somehow increase the risk of a person developing arterial thrombosis. Of course, that's not proven, that's just conjectures, and that should not be taken as a contraindication to a person getting the vaccination.
I would agree with you on that, Keong. In addition, I really like the idea of a pro-inflammatory state. Let's be very frank. The vaccine actually kind of stimulates your immune system, and when that happens, you have a pro-inflammatory state because all your cells are activated. But the same thing happens as well, if not worse, when you have an infection. When you have an infection, your whole body is stimulated, you have pro-inflammatory state, and we have already learned that you could actually have thrombotic phenomenon happening. So the other way of looking at it is, with the infection, you're going to get strokes. With the vaccines, you perhaps may get strokes. I'm using the word perhaps because there's no evidence for it, or if there is, the numbers are actually very, very small. So the person is going to get it with the infection or with the vaccine, but with the vaccine, the risk is possibly much lower. Okay, so at this point in time, despite this anecdotal experience, individuals reporting them, I'm still going to vote for a yes for vaccines, even with this potential risk of strokes. Okay,
So
not proven. On the stress, it's not proven.
No, not proven. Anecdotal reports from colleagues saying that they see patients getting strokes after vaccination, but it's not proven. It could be just plain bad luck, so we don't really know.
Yes, I mean, we've seen it in movies where it's like, what did you do to me and my family? And the guy suffers a heart attack. It's like, you see the stress of it all. Perhaps this event is giving me a heart attack. Okay. I'm going to jump on next to Cindy here. COVID, influenza, I mean, we're living in COVID. How can you differentiate COVID and influenza? From history to testing? What else?
Okay, yeah, so I'm just going to focus on children because I see mainly kids. I've not seen an adult patient in 20 over years. Okay, so basically what happens is that in influenza, the fever tends to spike really high in children. They really come down with a bad very bad myalgia, they're knocked out. If you talk to the parents, they'll say, my child's very lethargic, he's sleeping, he's tired. So that's one of the hallmark of influenza. And also they tend to have sore throat and all. But in COVID, the kids tend to be quite well. And the scary part of it is that they look like any other cough, cold, runny nose. Okay, how do you know whether there's a sense of smell is lost or not? Sometimes the young children are not able to tell you. So this is the other thing that sometimes may help us, but the older children might be able to tell us. And also the other thing that's maybe a bit difficult to differentiate between between influenza and COVID is that both of them can have a little bit of gastroenteritis symptoms. So I think mainly the fever and the severity of the illness really does help. To help differentiate the two.
Okay, we're going to down to the last 1 minute. Okay, I'm going to ask Dr. Chua. The top question is, are we seeing difference in the long COVID symptoms demographically in different regions? Do you want to have a try at that?
Okay, I will attempt, but the information I got from BMJ review article actually cited more than 60,000 articles written on long COVID, of which they took 200 over and synthesized it into the review article. So we're talking about a huge number of data, and a lot of the studies are pre-print or still in review state. So I think we have to take that into account when we look at it, whether the self-reported symptoms. But the general trend is that fatigue is one of the top reported symptom, and then followed by a third of them being cardiorespiratory, and then 20 to 30% neuropsychiatric symptoms. I think in the NCID experience, they also reported fatigue as well as dyspnea, residual shortness of breath, as one of the most common symptoms.
Okay, great. I think that's a nice short summary. This is an evolving field, so watch this space. I'm going to do the last question here. Hong Kong and mainland China seem to not have a late surge of cases in COVID-19 compared to countries using mRNA. This is not a comparison between inactivated vaccines versus mRNA vaccines. No, it is a comparison between strategies. Is it a zero tolerance strategy, or is it a case where living with COVID? The rest of the world, except for 2 places, have gone on to living with COVID. And we all know it. When you live with COVID, you're going to be exposed to it. You're going to have huge cases. And we saw that in Singapore, and we moved into it somewhere in May and June this year. Now, Hong Kong and mainland China, if you try to go into that country now, my friend, you have a 21 days quarantine. I was speaking to one of the nice sisters in the ward, and they tell me that if I want to go home, I have to be quarantined for a total of 56 days. If you were to go for this sort of scenarios, all kinds of viruses would have lived in you, actually went on a holiday, come back, died in you, and then buried or incinerated by the time you leave 56 days. So there's no way the virus can actually enter. But wait, the virus still entered. At the coastal regions, you actually have COVID cases in China. And when this happens, there's a lot of lockdowns. Fellow Parkway-Yanshins, fellow doctors, do you want another lockdown? I'm voting against it. I'm voting living with COVID and just getting on with life. Okay, so that will address the question why mainland China and Hong Kong doesn't have COVID. It's about strategies. It's not about vaccines. And certainly no politics involved. Okay, with that, I'm going to end this session. I think it was a great, exciting session. I want to thank all the speakers, the 4 speakers here again, as well as the 3 speakers here, as well as the 3 speakers earlier on. I think it was an exciting Saturday afternoon. And as usual, a Saturday afternoon, I can think of 99 different things to do, but you chose to spend it with us for learning on COVID-19. And for that, I think you have my vote. You are my champion. Thank you very much, doctors. Thank you.
Thank you, Dr. Leong. Wow. Yes, that was indeed a very, very insightful session. Yes, thank you so much. And of course, a big thanks to Dr. Banei Yang, Dr. Agarte, Dr. Wee Chee Keong, Dr. Cindy Hia, Dr. Elaine Chua, as well as our moderator, once again, Dr. Leong Ho Nam. And of course, we would like to thank our organizing committee, Dr. Richard Fan, Dr. John Chia, the CME chairman of Mount Elizabeth Hospitals. We also like to thank Mr. Yong Yi Ming, Dr. Peter Chow, Chief Executive Officers of Mount Elizabeth Hospitals. And we'd like to give a big shout out to our facility management, hospital operations, and media, and also our medical affairs and marketing team. Thank you so much for making this event possible. And of course, we'd like to give a big thank you to our gold sponsor, which is Sandoz. Thank you for your support. And next up, ladies and gentlemen, while you're watching this live, we'd like to enlist your help. We'd appreciate if you could also join us in giving us a post-event feedback. So please scan this QR code that's being displayed on the screen right now. So by scanning this QR code on screen, And do remember, if you want to type in the user on the browser for the URL, this is case sensitive, okay? And recording will be made available till the 31st of December this year, and after which we'll upload these videos onto the Mount Elizabeth Hospital's YouTube channel. With that, ladies and gentlemen, thank you for joining us for our annual event, and this is brought to you by Mount Elizabeth Hospitals. And of course, more importantly, thank you for joining us for such an insightful, engaging session as we overcome challenges and also navigate ahead in this age of disruption. My name is Charlene, and I hope to see you once again very, very soon next year for our next Mount Elizabeth Hospital's annual medical seminar. Goodbye.